Hello and a warm welcome to the Dr. Syl Podcast. Yes, today is episode 1. I just felt like starting a podcast, so here we are. In today's episode number 1, I am absolutely honored and stoked to invite Dr. Angus Finlay, a psychiatrist who works in Canberra, both in a public and private role, and who has extensive experience in managing anxiety and depressive disorders. So this was a very extensive discussion. We went for over an hour and we talked about what are anxiety and depressive disorders, and we talked about different subtypes. We also discussed some of the common symptoms, not only mental health symptoms associated with these disorders, but the physical symptoms and some of the lesser known ones that can kind of sneak up on people. And then once we looked at the different disorders and the different symptoms people can experience, we then had a really comprehensive discussion talking about the treatment from a psychiatrist's perspective, covering the biology, the psychology, the social, the religious, the spiritual, and of course the physical. And we really deep dived on the physical. We talked about diet, about exercise, about sleep, about a bunch of other things. And all in all, it just was a very comprehensive discussion, I felt. So this was our first ever episode on the Dr. Syl Podcast, and I absolutely loved it. I'm very keen to do more episodes like this. So if you liked it, the best thing you can do to support it is by liking the video and leaving a comment down below. And the comment can cover what you enjoyed about it and what do you look forward to in future episodes of the podcast. And is there anyone you wish for me to interview? So before we start, a quick disclaimer. I want you to understand that Angus and I are both doing this podcast in a personal capacity. We are not representing any medical specialist, college or institution or workplace. All advice here is intended to be general in nature. No patient-doctor relationship can be formed by engaging in this content. Please go see a doctor if you think you need support. And we do our best to be as accurate as possible, but sometimes there are inaccuracies. If there's anything you feel we said was inaccurate, just comment down below and I'll update it in the description or in the pinned comment. All right, now that's out of the way, let's get into it. So Angus, thank you so much again for coming on. This is a really important subject matter to talk about, anything that can help depression and anxiety. I think from my time, brief though it may be, but as a psychiatry registrar, I have seen that this is a global problem, that it's very common. Depression disorders, anxiety disorders, and anything that can help is worth talking about. And the evidence that's coming in the last couple of years around physical activity is impressive. So thank you for coming on to talk about it. But I also know as a registrar that sometimes I read depression and anxiety and it can mean so many different things in different people. So I thought maybe we can start a little bit by by defining the terms. So yeah, can you tell me a bit about what depression means to you?
Yeah, certainly. And Syl, thank you very much for inviting me on the podcast. Very excited. So as a psychiatrist, when I think of the word depression, I tend to think of major depressive disorder, though there are other forms of depressive disorders as well. But I guess the important thing to bear in mind is that depression is more than just a normal run of the blues that we all experience to some extent. Depression is a clinical illness that has certain things that it needs to meet, certain criteria that it needs to meet within the diagnostic manual that you're using. But fundamentally, it's an illness that affects a person's mood, the way that they feel about themselves, about the world that they're in, and perhaps about their future prospects as well. It can really reduce their ability to feel pleasure. It can have a profound impact on their body as well, physically, which is one of the lesser appreciated aspects of depression, and it can sometimes make people feel like life is so bad that it's really not worth living. So a really terrible illness to suffer from, a very common illness, and at any given time, somewhere between probably about 5 to 10% of the population in Australia actually have levels of depression that are enough to be diagnosed with major depressive disorder clinically. And from, I guess, a global burden of disease perspective, depression always ranks very highly within the burden of of disease. And anxiety disorders, I guess, are also really really challenging illnesses for the people who experience it. To feel anxious, we all have an experience of anxiety, and to a certain extent, anxiety itself is part of the human experience. But for people who suffer from anxiety disorders, that level of anxiety has gone far beyond what the normal spectrum of anxiety is, to the point where it's very debilitating for them. You know, they have a significant functional impairment. It holds them back in life. There's a range of different anxiety disorders that people can suffer from, but the main ones that I think about as a psychiatrist are what's called generalized anxiety disorder, where people tend to have anxiety that's quite free-floating and across a range of different stressors and triggers and things. Then there's other anxiety disorders like social anxiety disorder. There's certain phobias and a range of other problems that people can experience as well.
I noticed, when we do exams as junior doctors and medical students and registrars, you memorize the criteria and it's like a checkbox. But what I've noticed working with getting more experience clinically is actually the kind of feelings you get as the interviewer when you're seeing someone in a major depressive episode. It feels heavy. I guess everyone feels differently, but for me, if I'm speaking to someone who's in a major depressive episode and they're moving slowly and they're not eating and they're not sleeping, and like I feel that weight in me, and that I guess it would be called something like countertransference. And conversely, with anxiety, it brings up anxiety for me to speak to someone who's anxious. It puts me on and being aware of that for me helps me kind of regulate it, and so I'm not making the anxiety worse by being like, oh, what about this? What about this? So the self-awareness as a doctor is really important. But it's just such a profound illness that it's that you can feel it. However, there's also people with depression that have this incredible ability to mask it. And you find out sometimes retrospectively after significant, devastating events. But the reason I say that is because I feel it physically. And so, the physical elements of these mental illnesses are so important to appreciate. And I think that ties in a lot into what we're going to talk about today, which is physical activity and depression and anxiety.
Certainly.
Yeah, so could you tell us a little bit about how depression and anxiety can influence people's physical health?
Yeah, certainly. So would it be good if I start with maybe some of the more physical symptoms of each illness that people can experience?
Yeah, I think that's a great idea.
Okay, great. So I might separate it for depression and anxiety because there is a lot of overlap and people can have similar symptoms in both illnesses, but there are some differences as well. So maybe starting with anxiety, many of your listeners would be familiar with lots of the common physical symptoms of anxiety. So when we feel nervous, we feel our heart might increase. We can feel palpitations where our heart's skipping a beat. We can experience things like tremors as our body's readying itself in that classic fight or flight response. We might feel that we're sweating more from our palms. We might feel butterflies in our stomach, perhaps. Some of the more severe symptoms that people can experience include intense breathlessness, that sense of what happens when people have a panic disorder, the sense of feeling like they're choking or something so terrible is happening that many people actually believe that they're having a heart attack in the midst of a panic disorder if they've never experienced it before. So really, really profound physical symptoms. Our gastrointestinal tract is affected by it as well. So when people are anxious, classically we can see accelerated gastrointestinal motility. So we see things like diarrhea more commonly, but also nausea that can progress to vomiting as well, not uncommonly. Conversely, some people might find that when they're chronically anxious and stressed, things actually shut down and they become more constipated as well. So there's a range of different ways that it might manifest within your body.
Right. Yeah. I mean, even myself, I've had those symptoms when I've felt anxious before. And I think maybe it's, young 20s syndrome, but when I was in my early 20s and feeling anxious about exams, I wouldn't know that it's anxiety necessarily. I wasn't that in tune with how my emotions were manifesting. But I would just realize that it would be harder to breathe, that I couldn't get to the bottom of a breath. And I would start yawning And in retrospect, I realized it was actually a manifestation of anxiety because it was always around an exam or a difficult situation. And so that's a very mild version of how severe it can get, but that's how it affected me personally. So what about depression, and what are the kind of physical sides of, what's the physical side of depression?
Yeah, so I mean, depression and anxiety often go hand in hand, and so many of those symptoms people can experience in depression. But to give you, I guess, a counterpoint to think about, with the more severe forms of depression, like melancholic depression, which is what we were talking about earlier, that sense of people feeling really slowed down in their movements and actions, and in fact in a lot of their bodily functions, things slow right down as well. So so people can, from a physical point of view in depression, experience most of those symptoms that I mentioned to you earlier about anxiety, but also there can be really profound impacts on their psychomotor function as well. So people can feel like their limbs are much heavier. They can feel almost like suddenly their arms or their legs have turned to lead, and it becomes very difficult to pick them up and move them. I've
heard people kind of talk about how it feels like they're walking through deep mud.
Yeah, certainly. I mean, we've all had the experience of feeling tired and less motivated, but you magnify that 100 or 1,000 times perhaps, and that's the kind of things that can be happening to people physically when they're suffering really severe depression. Again, their bowel function can slow right down as well. It can be a really profoundly painful experience to be depressed. Some of the older psychiatry textbooks and authors spoke about that intrapsychic pain that can accompany depression. In some of my work, I work with people with pain disorders, and interestingly, when they become very depressed, they also become more sensitive to pain. And so when they're more depressed, they often need higher amounts of analgesia to manage their pain. Wow. So it's an interesting and bidirectional relationship, I think, with depression, because pain itself can also cause depression.
Yeah, and it's interesting to think of kind of the mind and body connections when we're talking about these illnesses, because it's very hard to be happy if your body is sick, you know, and so we do see a lot of people with depressive symptoms when they're in a state of acute illness. And often, you know, everyone's different, but you can get an improvement in mood as the body improves in its health. So if someone's having a kind of relapse of cancer or whatever the admission's for, maybe during the admission things are really rough, but you can see that the mood can lift as the physical state improves.
Certainly. One more thing that I'd add, I think we'd be remiss when we're talking about physical symptoms of depression, we'd be remiss not to touch just briefly on catatonia as well, which is a really extreme and severe form of illness that can accompany many different psychiatric and neurological illnesses. But there is a form of depression called catatonic depression, effectively where someone is so slowed down that they're almost immobile, they can be rigid, they can be mute, and they can not move for many hours at a time. I think it's a very interesting window into how people's brains function or don't function so well when they're really profoundly depressed. But it just goes to illustrate the effect of or the extent of the physical symptoms that people can have with depression.
That's right. And to anyone who's kind of, you know, heard that it's in your head, snap out of it, come on, just get out of bed. When you see someone with catatonia, it's such a physical state. This whole podcast is about the physical side of things. It's not something that someone can snap out of. And people have died in catatonia because they haven't gotten the necessary treatment. It is something that requires acute treatment. It's an emergency. So absolutely, mental illness is not just something you can snap out of. It's something that does need treatment. And there's so many treatments for depression and anxiety, which is good. We have lots of tools in the toolbox. Maybe we can give a bit of an overview of some of the different tools and then talk about how physical activity and that kind of stuff is part of a comprehensive kind of strategy.
Yeah, I'd love to. I think when thinking about the different tools that are available to treat illnesses like depression or anxiety, I think it really helps to have a framework. The one that I personally find really helpful is the biopsychosocial plus lifestyle framework. Okay. And there are other important components to that as well, like spiritual aspects and other aspects that are very central to a person. But I think it helps to break it down into those elements. So have you spoken about the biopsychosocial model?
Oh, I must have. If anyone has seen me talk about it, please leave a comment down below. It's my it's the cleanest way to kind of differentiate the sections of management plan. But I include cultural and social and cultural, biopsychosociocultural, religious. Those are kind of the elements I try and incorporate. But it's a good way to structure and focus different areas. So I guess the first but not necessarily the most important, because I've heard some people pitch it to be called the socio-psychobiological, to focus on other elements of it first. But anyway, we'll follow the biopsychosocial structure. It's biological. So what does that mean, and what does that mean for depression and anxiety? The biological element of treatment. Yeah,
sure. So the biological element of the treatment, I guess, is any treatment that fundamentally interacts with human biology as its primary aim to then modify the underlying illness process. So that includes, I guess that's a very wordy way of saying things like medications. Antidepressants would be the obvious example in this case, but a range of other medications that are not necessarily marketed as antidepressants can be very helpful in depression as well. Things like antipsychotic medications, mood stabilizing medications, stimulant medications they all have their role to play, and anti-anxiety medications as well. Then other sorts of biological treatments like neurostimulation, so that can include things like electroconvulsive therapy or shock therapy, which is reserved usually for the more severe treatment-resistant forms of depression, but can certainly be life-saving in some people. Transcranial...
and I've just got to make a point, because a lot of people who might not have worked in mental health or have watched too many movies, there's a lot of preconceptions around ECT and electroconvulsive therapy. But when you talk to a patient who was in the worst pain of their life from their depression, and they get better through very quickly, relatively to other treatment plans, through a course of ECT, and you see how much it can help people, that's the emotional side of things. Then you look at the studies which show without a doubt that it's a very effective and safe treatment modality for depression. Obviously not for everyone's depression, so it needs a psychiatric assessment. It's a very important and safe treatment. But you're then talking about TMS.
Yeah, so transcranial magnetic stimulation is one of the newer forms of therapy. It's been around for a long time now in a research context, but it's really starting to hit the prime time in terms of being readily available and incorporated into a lot of our treatment algorithms. And I think as more and more data is coming out on transcranial magnetic stimulation, we're seeing that it's effective and that it's safe and well tolerated, and it seems to be moving up within our treatment algorithms.
What kind of, just as a side note, what kind of tips the switch towards it being more mainstream rather than just a research tool? Was it that they kind of found the right brain area, or to stimulate, and then they found that the research showed that was the prefrontal cortex was the right place to stimulate, and so now let's get it happening clinically?
Look, I think it's a good question. I'm by no means an expert in this field, but medicine is and for very good reasons, is a very conservative field, because unfortunately the history of medicine is there's many examples of treatments that have been found to be very unsafe and very harmful, that have been rolled out on a very, very widespread basis. And so I think we have learned from that, and we now tend to be very cautious when introducing new treatments. There was a school of thought for a long time amongst psychiatrists that weren't practicing TMS that it wasn't a very effective treatment. I think the problem is that most of our treatments for depression, when you look at the likelihood of success with the first or second option that you try, we could have far more effective treatments than what we have, or we should have far more effective treatments than what we have today. So there's a lot of room to really optimize and look for more treatments, because that problem of depression is such a huge and unfortunately undertreated problem to date. And so as a result of that, people felt that maybe transcranial magnetic stimulation wasn't really effective, therefore didn't merit being incorporated into our algorithm. But as we're seeing more and more information about its effectiveness come out, and particularly more and more information about its safety when you compare it with other options, people are increasingly turning towards it, and now it's becoming more available and more affordable to the point where in Australia, where we practice, it is now actually accessible with a Medicare rebate, so people can actually have a course of transcranial magnetic stimulation that's partially or potentially even fully covered by a government Medicare rebate, which has really changed the landscape for people, because it isn't a cheap treatment by any stretch.
Okay.
So that's TMS.
Yep.
There's a few other neuromodulatory techniques, such as transcranial direct current stimulation, for example. There are other more experimental type treatments like magnetic seizure therapy that are being investigated as well, but they're not really being used widely in a clinical context as of yet. Then I guess the other biological treatments include things like ketamine or esketamine, which is garnering a lot of interest around its ability to work perhaps as a neuroplastic agent to help people with treatment-resistant depression.
So that's an awesome summary of the biological section of treatment, but there's so much more to it. So there's psychological. We could probably just do a quick overview of the psychological elements of treatment too. Yeah, I'm happy to give that a crack, and then you can fill in the gaps.
Sure.
Well, I guess when I think about psychology for depression, everyone, when we talk about depression, we use a descriptive model of the symptoms that you see, but people can have very different etiologies for their depressive episodes. Much of the time we don't figure it out, but through psychotherapy, sometimes people can discover that the depression is a result of a complex trauma process, and anxiety too is a result of a complex trauma process from earlier years. It can be part of a PTSD, it can be part of all sorts of things that can be discovered through therapy. And so therapy can partly help with discovery of cause, but doesn't need to for it to be effective, because it can just be used for identifying the kind of maladaptive, unhelpful thinking styles that can cause some of these depressive symptoms. And so that's what CBT is all about. It's all about picking up on the less helpful thinking styles, and then using different strategies that you and the therapist will work together on to try and target those thoughts and ways to think in a more helpful way. And the evidence is great. So I think CBT is the kind of big one, but there's lots of other therapies that are very effective as well, and psychodynamic psychotherapy and schema mentalization based can be really helpful, and dialectical behavioral therapy if there's also emotional instabilities as well. So those are kind of what comes to my mind. Was there anything else you wanted to add in terms of the psychological treatments for depression?
I think you've given a really good kind of overview of several of the main modalities. There is some regional difference in terms of the main modalities that are available as well. So in Australia, another very commonly used modality in addition to CBT would be interpersonal therapy as well. Yeah. And then over in the United Kingdom or the USA, you might find people who are more schooled in things like cognitive analytic therapy, for example. So it depends on where you are. One of the essential components of therapy, as well as that therapeutic alliance and having that space to really explore someone's thoughts and processes and things with a therapist, can be so helpful. But also crucially, another really important aspect of CBT is not only identifying some of the cognitive processes that are underlying the illness, but also implementing some behavioural change to overcome that as well. Right. And therapy can be extremely effective and often is is the most appropriate option for depression, particularly when you look at the evidence around response in mild to moderate depression. Often therapy is what's needed, and that can help to really be, in a way, curative in a way that sometimes antidepressants aren't, but there are a proportion of people who are very fortunate who respond really well to antidepressant medications as well, who might not need therapy. So it really depends on the illness. Yeah,
it augments.
Well, that's the evidence that we have, that combination is best. But I think that what it speaks to is that depression is a very multifaceted syndrome. And earlier I referred to it as an illness, but really it's probably a syndrome of many different illnesses that lead to similar sorts of symptoms and presentations that we group together under that heading, major depressive disorder. The fact that so many people will respond to different forms of treatment just speaks to the importance of individualising treatment and working with people to see what will be best for them, what they respond to and what's acceptable.
Yeah. One point I'd just like to kind of repeat when we're talking about psychological therapies is the importance of rapport. The rapport is, I think it's not contentious to say, the most important part of a lot of these therapies. And someone can be an expert in CBT, but if there's no kind of connection with the patient, it's not going to be fruitful. And so, just because you've tried CBT with one person doesn't mean that it's not going to work with anyone. And so sometimes it can be a bit of work, but you have to find the right fit and commit. And it's a partnership. You've got to work together to both observe what's happening in yourself. But that's a great overview of the psychological elements, and we're getting towards the lifestyle, but there's a couple more steps first. Why don't we go through the kind of sociocultural aspects of treatment for depression and anxiety?
Certainly. So I will preface this by saying that the sociocultural aspects of depression and anxiety are enormous, and we could dedicate hours and hours to speaking about this as well. You mentioned earlier that some people speak about reformulating the biopsychosocial model to perhaps become the socio-psychobio model. And it's true, again, different people's illnesses will require adaptations and changes in different areas. The social and cultural background within which people live and develop these sort of illnesses is extremely important to pay attention to, because often treatments like biological and psychological treatments stand less chance of being effective if some of the issues that are reinforcing the illness from a social point of view aren't necessarily corrected as well. And so if we're thinking about social treatment options and things, in Australia, we're very lucky to have access to the National Disability Insurance Scheme, and so that can offer people access to things like support workers, to assistance at home, to aspects around looking after themselves, looking after other family members as well. Sometimes financial assistance can be really, really useful for people who find themselves in dire straits, perhaps because of their illness, or that might have been something that caused them to develop their depressive illness. I guess, Syl, what sort of social interventions have you seen to be really effective in your time?
Well, it's very clear to me that if someone has good social supports, they have better outcomes than someone who is isolated.
Absolutely.
These disorders or illnesses, it's very hard to get through them alone. And having even one good connection is very helpful. It's almost as important as having a good kind of antidepressant.
Every bit as important.
Yeah. If I could prescribe a support worker as part of the thing, I would prescribe it. But I wanted to also reflect on a kind of cultural, just the way, I wanted to reflect on how socioculturally our lifestyles have become a little disembodied compared to in history how they were, and how that could relate to doing exercise and how that can help with anxiety and depression. Because when I think of what the modern life can be, not for everyone obviously, but when I think about someone who is waking up, is working at a computer all day and watching TV and I was on the phone for the time in between. To be in a phone, to be on a screen, it's a disembodying process. You're not connected to what you're feeling. You're not connected to your body, and you're often quite still. 100,000 years ago, we were mobile. I mean, we've evolved to be mobile creatures, not mobile creatures. So we'll have to not edit that out, actually.
You'll need to add a brumch in.
That's right, in post. But you know what I mean? Like, and so I think one of the reasons that doing all this exercise is so helpful is that it's reconnecting us with a primal need to know our bodies, to use the vessel in which we explore consciousness in, and it's. I'm not saying that's the cause of depression, but it can be a contributing factor when you're having a very disembodied life. And in trauma as well, and people who dissociate often can have comorbid depressive disorders. And part of coming out of dissociation is learning how to reconnect with the body, and that's what grounding techniques are all about. So that was just my rant around society. Sorry to change tack there for a sec. But yeah, that would be kind of sociocultural things to address. And that's why I'm really getting into camping, actually. Videos to come. But so that's sociocultural. And then you said the fourth part of your treatment kind of approach is lifestyle. Well, that's why we're here. Yeah. So tell me about it.
Well, look, I think lifestyle is often neglected, and often that's probably because there seem to be fancier, shinier treatments that we can give acronyms to or prescribe medications for. But lifestyle factors are so crucial in perhaps causing illness and then preventing someone's recovery. So actually addressing them and optimizing them can be really effective. And it should be done, in my view, for anyone who's unwell enough to seek help from a clinician specialised in mental health, or a general practitioner or any sort of health practitioner, really. I think that we miss an opportunity to help people recover if we fail to address some of the lifestyle factors that might be contributing. So the way I think about lifestyle is in a few broad categories. I think about substance use, if there are harmful substances that might be driving a depressive illness, and in turn a depressive illness can also drive consumption of more harmful substances as well. I think about exercise levels, I think about diet. I tend to think about socialisation as well within that lifestyle aspect, how much contact people have with their loved ones or their friends or people who make them feel connected and part of a community, because that is so important and it is such a fundamental need for so many people. So those are the broad sorts of factors within the lifestyle category. There are other things like daily routines and sleep hygiene and use of technology that also would be subsumed under that heading.
Yeah, sleep would be a major one there.
Yeah.
So I guess if we're kind of getting into what... we've talked a bit about depression and anxiety. We've talked a bit about the physical side of them. We then talked about how the treatment plan the comprehensive plan involves all these things. What is the evidence showing us around what people should do in terms of exercise for depression and anxiety disorders?
Yeah, sure. Well, I guess the first thing I would say is that not everyone can do the same amount of exercise. There might be different things that preclude someone from exercising, different health conditions, different access to equipment, or different time constraints or financial constraints. But in a perfect world, if people can exercise and they do exercise, we will see that there are improvements in anxiety and depression. But what has been shown in the studies that have been done to date is that the exercise does need to meet certain criteria. And so the first thing that I would normally say to people who come and see me, to my patients, is that any form of exercise is better than not exercising. So to be able to do what you're able to do is great. But if you're looking to really optimize things, then my recommendation is normally to try to aim for at least 3 times per week, about 30 minutes per session. More is usually better within reason. But 30 minutes per session of at least moderately intense exercise. So it's the kind of exercise where you get puffed and it makes it a bit uncomfortable to talk. If you can do more than that, more high intensity type work, then that's excellent. And it has been shown to be more effective for alleviating anxiety and depressive symptoms. But already, if you can do moderate intensity exercise, at least a couple of times or 3 times a week, then that's great. And we see significant effect sizes. It depends on the severity of the depression as well, but certainly in the more mild to moderate depression, we see effect sizes that approach that of antidepressants. Now, what I mean when I say an effect size is the ability of the particular intervention, in this case exercise, to make a difference to the symptoms. So basically what that means is that exercise in certain people can be as effective as antidepressants in certain people in depression. So a really big thing, and to not do that deprives people of a chance to recover. So generally, by the time someone is coming and seeing me, they're probably going to be doing therapy. They're probably going to be on an antidepressant. They might not be exercising and say, hey, this is the low-hanging fruit here that we can look at really optimizing for you. And the same holds true for diet. I don't know whether you want to talk about diet now or whether you want to stay on the exercise side of things, because there is more information that we could discuss with regards to types of exercise as well.
Yeah, maybe let's hold the exercise focus for now. But diet, I would love to talk more about that. From what I've read, it does seem like it's a dose response, that more exercise within reason and also more intense exercise seems to be more helpful. I am a little curious to know whether it's if the cohorts that are able to do more exercise might have a milder form of illness or an illness that's more responsive to exercise. And I haven't dug enough to kind of work out the severity levels and if they're controlling for that well. Whatever the case, more exercise is great, but any is better than none. And it can start right now while watching this video. You can just do a couple of squats, half squats. You can just stand up from a chair and sit down on the chair. You can do it with assistance if you need. It's just a matter of starting. But do you have any insights on how you've helped people who just really struggle to start?
It's challenging, and speaking from my personal experience as well, the amount of times that I've started a gym regime and it's dropped off very quickly because of all the different things that life has thrown at me.
Gyms
and
love that.
Yeah. And I've been lucky enough not to be confronted with a really serious mental illness like depression. Trying to do that when you have a really serious mental illness is so much harder as well. So that's one thing to bear in mind. But I think it's really important to be kind to yourself and to recognize the fact that anything is better than nothing, and that every time you try something, even if you can't make it stick perfectly, you learn through that process and you get more and more successful at it. The tips that I tend to give to people is just to do something that they know that they enjoy doing, or perhaps if they're so depressed that they don't really have that experience of enjoyment anymore, something that they know they used to enjoy doing as well, because it can be so gratifying as they begin to recover from their depression when those sparks of enjoyment start to come back to them doing something that they used to do. I think it's very hard to start doing a new form of exercise if it feels like a chore. It's just not pleasurable or enjoyable, so it's really rare that it will stick. So it's much better to do something that is enjoyable to the individual. And for some people that might be solo exercise, that might be walking, that might be running, that might be swimming. Some people might do better in a team environment. Some people might like the accountability that comes with turning up and playing with a team, and also that brings a social aspect to it as well, which can be really helpful for some people. It really depends on the individual and what they like. So we'll often look back at what sports they've done in the past and what they've enjoyed, and then try to establish a plan around that.
I mean, my two reflections. The first is being kind to yourself is kind of the most important part of it, because if you have, these expectations of what you should achieve and you're failing at that, then it'll just become another part of the illness of why you're feeling down. But you need to look at what you have achieved and how that's, an improvement from not doing any.
Absolutely.
And the second is how, this is kind of a missed opportunity, and that often people are getting to a psychiatric level of care and haven't had a good psychoeducation around how important exercise is in their treatment. And It's almost like we need exercise physiologists to team up with GPs to kind of let people know in primary health settings how important it is for mental health and general health. But that's a great strategy to kind of go back, because someone with anhedonia, the inability to experience joy, I haven't thought to kind of go back to what they used to enjoy. But if someone is doing a multimodal treatment and, like with an antidepressant and exercise, neurons are remapping. And if what they're doing exercise that's stimulating all sorts of good things for the neurons, and they get those sparks of joy, then you're going to map a relationship with that exercise that'll be very positive, and that's really nice. So that's a really good insight.
So I'm glad that you mentioned the impact that exercise can have on people's brains and neurons. And I think that because it's such a topical theme at the moment, we'd be remiss to not discuss the role of brain-derived neurotrophic factor, or BDNF, which is very much an in vogue molecule at the moment for very good reasons. So brain-derived neurotrophic factor, that translates really, a neurotrophic factor is something that promotes nerve growth. And there are a range of different neurotrophic factors. Brain-derived neurotrophic factor is one of the best known of them. When people do exercise, we can clearly measure increases in the serum concentration of BDNF out in the periphery, and certainly we know that it rises in people's brains as well. Why that's important is because BDNF is one of the molecules that promotes that growth of neurons. It supports neurons to stay healthy as well, and it prevents or it reduces the likelihood of a neuron dying if it's confronted with a certain insult. So BDNF is a really essential chemical within our brain. Doing exercise stimulates that BDNF release. And interestingly, that's one of the common pathways through which people recover from depression. So there's a proportion of people who have low BDNF levels when they're depressed. As they recover from the depression, their BDNF levels rise. And we see that with lots of different ways of addressing it. We see that with psychotherapy that someone responds to. We see that with antidepressants. We see that with electroconvulsive therapy. And we certainly see that with exercise as well. It's important because BDNF not only helps people recover from depression, it also helps neurons form new connections, so new synapses between one another. It promotes genesis of new neurons in certain areas of your brain, like the hippocampus, where new neurons can form as an adult. And really crucially, even for people not suffering from depression or anxiety or any other mental illness, it can help to improve their cognitive function as well. And so it can reduce the likelihood of dementia. We see that people who are not doing exercise, who then do regular and quite intensive exercise, can actually boost their grey matter volume to the point where we can see that on MRI scans. And from a personal point of view, I can certainly feel a significant difference. Obviously, that's quite anecdotal, but I can certainly feel that I'm much sharper cognitively when I'm exercising regularly than when I'm not doing anything at all. And I think a lot of people would have that experience as well. So just another selling point for the benefits of exercise, because it is so useful, in addition to being a really helpful thing for your physical health, particularly as people are aging. Exercise is great for your muscle mass. It's great for your insulin metabolism, for staying healthy, for avoiding things like diabetes, for avoiding things like osteoporosis because your bones are thinning. And interestingly, when you look at the correlation between overall muscle strength, there are some really interesting studies done looking at using grip strength, for example, that have found that people with lower grip strength are more likely to develop depression in subsequent years. And interestingly, as people's muscle strength increases, then they're more likely to actually remit from depression if they're suffering it.
Yeah, that I'm sure the grip strength trainers are going to sell like wildfire. But I mean, when I hear those studies, I see the grip strength as a proxy for general health, and just a very easy measure to kind of suggest that someone has had a life where they've used their body, because that's the most distal part that you would have interacted with the world.
Yeah, well, grip strength is a very easy thing to measure in a study environment that doesn't require much specific kind of equipment and things, so it lends itself well to those kinds of studies.
And talking about BDNF, I'm wondering if one day there'll be just a supplement that people will be taking. I'm sure there probably is precursors to it that people take. But to measure it in someone's serum level is, it's like, it's so far from the brain that it must be so profound if it's making its way to the serum and you're seeing changes in the serum. It must be extremely profound changes in the brain because it's got to go through the whole CSF and then into the bloodstream. So it's like taking a cup of water from Bondi and measuring it and saying that the water in Mexico is it's got a certain chemical in it. So that's it's a big distance for BDNF to travel. So it's clearly going to have a big effect. But speaking around BDNF and supplements, it's probably now a good time to talk a bit about diet. I guess my approach with diet and general health is just the less processed and keep it diverse. As two general rules, that's kind of what I follow. What do you know about diet and its role in the treatment for depression and anxiety disorders?
Yeah, so I think diet is very important, and I think it's certainly an aspect of that initial assessment that I look at, because it's very hard for someone who's struggling with an illness like severe depression to be able to, I guess, plan ahead to buy healthy food, to prepare it, to cook it. And so it is often another one of those relatively low-hanging fruit that people can actually try to utilise to recover. And in addition to other forms of management, whether it's psychotherapy, whether it's antidepressants or other kind of biological management, again, diet is one of those things that can and probably should be looked at the same time. So my advice to my patients is actually quite similar to what you do. So trying to avoid the ultra-processed foods. So that's foods that contain lots of preservatives, different flavour enhancers and things, a range of other compounds that simply aren't found in more natural foods that usually are designed to either enhance the palatability of the food or the shelf life and things.
And we probably shouldn't name exact brands, but if you look at the food and you can't really tell what's in it, it's probably very processed. Yeah,
certainly. So generally, the fewer ingredients, the less processed it is, especially if you recognise the ingredient names.
Yeah, if the ingredients are numbers, that's a bad sign.
Absolutely.
Flavour 1122
Absolutely. It doesn't sound very natural, does it? But so avoiding the ultra-processed foods is a very good start. And in fact, this is an area of mental health research that is still quite nascent, still really developing. One of the first trials that I'm aware of that really seriously looked at incorporating aspects of a Mediterranean diet. So a Mediterranean diet is, your listeners can look at the specifics of this online, but really a Mediterranean diet is a diet that is, again, free from highly processed foods. It tends to be quite high in vegetables, fruits, unsweetened dairy, nuts, different legumes.
And unsaturated fats as well.
Yeah, high in unsaturated. It's certainly high in unsaturated fats like olive oil. Relatively low quantities of red meat, some quantities of fish and things as well. I will often prescribe that to my patients. And it's not a specific diet per se, as much as a set of dietary principles to adhere to. So one of the first studies that actually looked at using that in a treatment capacity was a study done in Australia called the SMILES study. And that's similar. That's since been replicated in several different countries. This study was...
Sorry, I just have to address the... I don't know if it's irony, but the fact that the Mediterranean diet was first proven effective for mental health benefits in Australia. Is that what, is it the first study that used Mediterranean diet for?
It's one of the first really rigorous
Mediterranean diet.
Yeah, certainly one of the first rigorously controlled, randomised studies that used it in a clinical context in a depressed population. Yeah. So that particular study actually found it had two arms, and I promised I wouldn't go into too much detail with studies and things. So bear with me on this. But it had two arms where effectively people were randomised to the intervention group, where they were provided with a lot of information about the Mediterranean diet. I believe they may have actually been given the ingredients for Mediterranean diet, but I'd have to go back and look at that because it's been some time since I've looked at that study. And in the other group, I think people were in an active control group where they were given maybe some support and things ongoing. So it wasn't as if one group got a lot of clinical attention and one group got no clinical attention at all. And about a third of the people in the dietary intervention group actually remitted from their depression, which is huge. Whereas in the control group, only about 10% of them remitted. So it was a huge effect size. Really, I think that study was published in maybe 2017 or so from memory, and something that has that level of effect size we don't see all that commonly in our field. You know, for antidepressants in severe depression, which are considered gold standard treatment, we tend to see effect sizes of around 0.7, which is considered a large effect, but it's still overall shifting the dial only so far. And this particular study found it to be more significant than that in a more mild to moderate form of depression. So it has been replicated. I'd have to look at the literature to see whether the same effect size has held true. But
I also like to mention, when people hear about this and they go, oh, look, it's too hard to afford health. Well, unhealthy food is cheaper, in the short term. But what I try and remind people of is that actually, if you eat unhealthy food and you develop health complications, and then that affects work and you pay money for meds, at the end of the day, getting healthy food, paying a bit more for good quality, unprocessed stuff, it's going to save you money, and you'll just feel better. It's priceless to have a better life, right?
And do you know what this SMILE study that we're talking about, the authors of that study were ingenious, and they actually worked out with the study participants how much they were paying on food. With their more unhealthy kind of diets before the study, as compared to how much the people in the dietary intervention group were paying subsequently. And they actually found it was about $15 a week cheaper living in Sydney to be eating the healthy food.
Whoa! Oh, that's interesting.
Yeah, maybe. Yeah. I mean, that doesn't factor in necessarily the time involved in buying and planning and preparing.
Oh, sure.
But certainly the cost of the actual ingredients was cheaper.
I used to really not like cooking, but I think once you start buying nicer quality things, it's more enjoyable. Yeah. Well, that's a very interesting study. So that's something you would prescribe to patients, because you think about prescriptions in terms of medicines, but absolutely we should be able to prescribe exercise and diets and as part of a treatment program. So you would prescribe a Mediterranean diet.
Absolutely. When people see me for depression, if any of my patients are watching on, they'll know that they leave with a handout on the modified Mediterranean diet guidelines. And there's many different versions of that available online. Interestingly, I actually give a copy of guidelines that were originally intended for people recovering from cardiovascular disease, because this food is also healthier from a physical perspective as well, not only mental health, but physical health.
Wow. Okay. Was there any other dietary advice that you wanted to discuss for depression and anxiety treatments? That sounds like a really cool one.
Yeah, look, I guess that's about where I tend to leave it. I recognise as a doctor, there are people who are far more qualified to advise on diet than me. So not uncommonly, I'll refer my patients to dietitians, particularly if I think there are some dietary factors that need addressing, or perhaps if people would benefit from having a nutrition plan prepared. And there are dietitians who do have specific mental health interests as well.
That's what I was going to ask.
Yeah.
I wonder if there's anyone watching who's a dietitian with a mental health kind of focus. I wonder if mental health referrals to dietitians have been increasing, which would make sense because of the brain-gut axis and the effects there.
I think the other, I don't know if this counts as dietary advice or substance-related advice, but often people underestimate the impact of certain substances on particularly anxiety. So I can think of several occasions this year where I've seen people who are having up to 10 to 15 caffeinated beverages a day, and they're coming into me anxious, and then we look at that and say, well, let's try cutting this down. And often that in and of itself is as effective as any form of therapy or antidepressant medication, if not more. So I think it's really important to attend to that.
I also think on the coffee note that there are people who may feel they don't feel caffeine keeps them awake, or that they feel they don't feel caffeine sensitive, but they might still have bodily reactions to caffeine, like an increased heart rate, and then have a biofeedback effect that can make them feel more anxious. So I have a friend who felt very caffeine insensitive, but did get increased heart rates. And so it's, maybe not sensitive in terms of feeling awake and alert, but definitely sensitive in other ways. So yeah, with coffee, I recommend stopping before 2 p.m. if you can to not affect sleep, which we hopefully can talk about. And 2 cups a day. It's not realistic for a lot of people, but it's a good place to aim for. 1 in the morning, 1 at midday, and you should be good. Yeah. Sorry, you were saying?
Well, I think that's about the limit of dietary advice that I provide, and I'm sure that in many other cultures there will be different sorts of diets that incorporate a lot of similar aspects to the Mediterranean diet in terms of, avoiding the ultra highly processed foods and using lots of unsaturated kind of fats and things that may also be as effective, if not more effective, who knows, where perhaps the studies haven't yet been done. So I think it's an area that we really do need to follow, but certainly trying to practice as an evidence-based clinician, the evidence base is certainly around the Mediterranean diet for anxiety and depression.
And maybe to close, we can talk a bit about sleep.
Certainly.
Because that feels like the kind of third important physical health area, really. Who knows what happens when we're sleeping, but whatever it is, it's important. That's my kind of summary of all the literature. It's very complicated, but when people don't sleep, everything seems to go worse. So how do you advise someone around sleep and sleep hygiene and why it's important in depression and anxiety?
Yeah, it's a good question. So I guess one of the things to bear in mind with both depression and a range of anxiety disorders, sleep disturbances are part of the diagnostic criteria. They're often a fundamental part of the illness. And as a clinician, I'll often ask my patients about how they're sleeping because it can be one of the first indicators that something it might be a little bit awry, or they might be going from a period of stability into relative instability. So sleep is really, really important for recovery from depression. Being well rested also helps people to be much less sensitive to anxiety in general. So with that in mind, and recognising the impact that the illnesses that people are experiencing can directly affect their sleep, there are still lots of things that people can do. So one of the first things that I will do is actually assess a person's sleep pattern. So I'll usually ask a person what time they go to sleep, whether they're waking through the night, how long it takes them to get to sleep initially, what time they wake in the morning, what the nature of their sleep is like. Was it a good, refreshing sleep, or do they wake up still feeling really tired and flat? Whether they're napping during the day as well, because often that fatigue that accompanies depression can cause people to nap for long periods of time, and that can then impact on the quality of sleep that they're getting overnight as well. And so once we have a sense of where their sleep is at, it can also be helpful to use things like sleep trackers. It seems like everyone has a smartwatch these days, and that can also provide additional useful information, though you do take it with a grain of salt. Different ones are more accurate than others. But interestingly, our subjective perception of our sleep doesn't always match up with the reality, and often people will think that they have slept a whole lot less than they have as well. So when you get people into a sleep lab, they might say that they've only slept for 3 hours, but actually in the sleep lab you can see that they might have slept for longer than that. That being said, there are plenty of people who struggle with insomnia, and I know, being a light sleeper, not someone with a clinical insomnia disorder, but being a light sleeper, struggling to sleep is a really challenging thing. Coming back to optimizing sleep, though, with respect to sleep hygiene, there's a lot of basic principles that people can do, and many people will already be doing many of these things, but I would usually go over it if someone is struggling with sleep. So things like avoiding caffeine, and it might be, if someone's a slow metabolizer of caffeine, it might be actually cutting out caffeine before midday, for example, or trying to cut out caffeine entirely. It would be looking at other...
How do you find out if someone's a slow metabolizer? Do you have to do is that a genomic testing kit that someone can do, or is it you just kind of work out that the caffeine affects them for a longer period of time?
I guess it's partly a theoretical kind of idea. If people if they feel that they're more sensitive to caffeine and they feel wired and then they go off caffeine and their sleep normalizes, you can look at pharmacogenomic testing of some of the enzymes that break down caffeine, but it is expensive and it's certainly not something that I would use clinically. Okay. In that case, I use pharmacogenomic testing in other contexts certainly, but not to determine if someone's a fast or a slow caffeine metabolizer. Could just try a day without caffeine. Yeah, exactly. But it's worth having that discussion. And then other factors include just optimizing that environment for sleep. So, making sure that people aren't taking their smartphone to bed is a really big one.
The screens, that blue light.
Yeah, but I think it's more than just blue light. Blue light's certainly part of the story, but there is something that's very activating about having a screen there, particularly these apps that are designed to keep our attention for as long as they possibly can. It becomes very hard to put it down, and all of a sudden you're losing half an hour or an hour of sleep every night because you're too tired or perhaps struggling with the motivation to actually just close that phone off, or the phone's dinging overnight, or whatever it happens to be.
Connecting to what's happening in other countries. That's very distressing.
Yeah.
That horrible gambling-like psychological effects of these apps.
Yeah, absolutely. So as a general principle, the best thing people can do is have a kind of a time where there's no exception to it, but that they put their phone in the cupboard somewhere else outside of their bedroom at a certain time when they're winding down to go to bed. Having a good bedtime routine is really important. That includes doing things like dimming the lights at home. People might choose to have a shower around that time. They might be winding down, avoiding, as much as I'm a proponent of exercise, avoiding really intense exercise in the late afternoon and evening, because that can make it very difficult to sleep if your body's really...
I'm very sensitive to late exercise.
So am I.
It will affect my sleep.
That's
what I try to do in the morning.
Yep. Making sure that people have had enough to eat. But then there's lots of great online resources around sleep hygiene. I'll often prescribe sleep hygiene therapy modules through one of my favourite online platforms as well, that people who are people who are already doing many of the right things find it very helpful to work through that. And in fact, there's also forms of CBT that are really effective for sleep as well. CBT for insomnia can be really, really useful.
And the only thing I'd like to add is what you do first thing in the morning, because a good night's sleep starts with what you did the morning before. And the best way to start all the circadian rhythms, because there's lots of different hormonal and biological processes happening throughout the day, is to get exposure to sunlight. And there is nothing like the lumens of the sky. A cloudy sky, looking at a cloudy sky, is orders of magnitudes more lumens, light intensity, than fluorescent lighting in an office. And when you're getting those lumens, it's affecting the cortisol levels, the melatonin levels, the adenosine levels. It's all important. It's all getting, you're letting your evolutionary biology start. But a lot of people do start their day inside in dim light, and then go into the car and to work, and they don't get that big kind of hit of light. And it helps you wake up as well, which is, people do appreciate waking up quicker as well. Wow, that's been a really enlightening and awesome talk. I'm just so grateful. It's like having a one-on-one lecture. But I hope that's been really helpful for other people. Was there any other closing points you wanted to discuss today?
I don't think so. I think that's hopefully given people a lot of things to think about, and a lot of different things that classically aren't addressed that are options that can help people suffering from anxiety and depression to look at and take back a bit of control as well where possible. So I'm really grateful for being invited on. Thanks very much.
Thank you. And I think a closing kind of takeaway that I would want people to remember is to just be kind to yourself. It's very hard to get started, but doing anything is better than nothing, and you can do it, you know. So I just wish everyone the best if they're struggling, or if they know someone who's struggling. Good on you guys for supporting them, and keep up the awesome work. And thank you deeply for coming on. That's really, really awesome, and I really appreciate it. I hope to have you on again soon. But other than that, I wish you all wonderful days full of connection and love, and we'll see you guys in the next episode.
Thank you. See you later.